Hello and welcome. My name is Alex Poppin, PharmD, and today I'm going to be discussing the difference between statistical significance and clinical significance. I've put this together because statistical significance and clinical significance often get mistaken for one another, or rather, students and professionals aren't aware that one does not automatically equate to the other. And this can lead to misinterpretation and misapplication of trial results, which is why understanding the difference between the two is so important in the practice of evidence-based medicine. Again, please note that this is not meant to be a comprehensive review, and I am not an expert on biostatistics. But I do feel confident that today's review will help provide you increased clarity and confidence when interpreting trial data. So let's get started. Let's first start by reviewing what statistical significance actually means. To do this, we need a quick refresher on p-values and their relation to the level of significance, aka alpha. P-value is the probability that the observed difference between two groups for a specific outcome is due to chance alone. And the p-value gets interpreted relative to the level of significance, aka alpha. Alpha being the chance that the investigators are willing to take that the observed results were due to chance alone. And this is typically set at 5%. If the p-value is less than alpha, then the outcome is considered statistically significant, because the probability that it occurred due to chance is less than the accepted risk. Clinical significance, on the other hand, is a little harder to define, because it deals with so many factors, which we'll go into. But the most important concept to recognize is that statistical significance does not automatically translate to clinical significance. For example, in this trial, we have two groups with event rates of 20% in Group A and 17% in Group B. The p-value is less than alpha, so the trial can claim a statistically significant reduction. But is it a clinically significant reduction? And this is really the ultimate question we want to answer at the end of the day. It's fairly straightforward to determine statistically significant differences, but the same cannot always be said for determining clinical significance. Let's say that this trial was testing a new drug taken every day for 1 year to reduce the occurrence of nosebleeds in otherwise healthy patients. Group A was placebo and Group B was the active treatment group. We've already established that the difference in event rates between the two groups is statistically significant, but is the 3% overall difference clinically significant? What if we say the outcome was all-cause mortality? Suddenly, I feel a lot better about calling this reduction clinically significant. And the point I'm trying to demonstrate here is that determining clinical significance is much more difficult because it involves a lot more factors and considerations. For instance, the measured outcome needs to be considered. Is it a serious event like hospitalization or death, or is it less severe like nosebleeds? Additionally, the trial duration needs to be considered. Did the observed results occur in 1 month, 1 year, or 10 years? And was this enough time for said events to occur? And while there is no one perfect trial duration, this information is helpful for understanding over what period of time any benefit occurred. A 3% mortality difference occurring in 1 year sounds better than 10 years, since the treatment benefit is provided much sooner. Safety also needs to be considered because treatment benefit of any kind can be outweighed by severe side effects or safety concerns. For instance, a 3% absolute reduction in mortality is much less impressive if there's a 30% absolute increase in hospitalization for heart failure. This would also limit the applicability of said drug in clinical practice, given the risk for causing significant patient harm. Number needed to treat and number needed to harm can be used to estimate a benefit-risk ratio, with a number needed to treat less than number needed to harm generally indicating a favorable benefit-risk ratio, since the benefit would occur prior to any potential harm. And a number needed to treat greater than the number needed to harm generally indicates an unfavorable benefit-risk ratio. For a refresh on calculating NNT and NNH, check out my review on biostatistics. And please note that this is by no means a complete list of considerations when assessing clinical significance, just a select few I personally use often. So we've covered some good info on assessing for clinical significance, but the only examples we've talked about were dealing with event outcome endpoints such as nosebleed or mortality. What about trials where the primary outcome is blood pressure lowering or weight loss? Another thing to understand when determining clinical significance is knowing when a surrogate endpoint is being used. Surrogate endpoints such as blood pressure, weight change, or A1C change are used in place of actual event outcomes for morbidity and mortality. And while there's ample data on the benefits of appropriately reduced blood pressure, weight, and A1C, the ultimate reason for lowering these values to begin with is to achieve actual lower morbidity and mortality event rates. So while they do provide helpful information, surrogate endpoints are less reliable than the actual event outcome measure, since they only predict treatment effect. So how do we determine the clinical significance for trials that use surrogate endpoints? Let's look at another example. This time, the trial is reporting A1C values. After the trial ends, the average A1C in Group A, the active group, is 6.1%, and 6.7% in Group B, the placebo group. Again, the difference is statistically significant, but is an A1C difference of 0.6% clinically significant? Luckily, there are established thresholds for clinically significant changes in certain surrogate endpoints. And while these values don't exist for every surrogate endpoint, the most common ones tend to have them. For example, a clinically significant reduction for blood pressure is considered any reduction greater than or equal to a 5 millimeters of mercury systolic. For body weight, any reduction greater than or equal to 5% of the total body weight. And for hemoglobin A1C, any increase or decrease greater than or equal to 0.5%. And again, these are generally accepted values that were derived from analyses demonstrating a predictive effect for achieving said value change. So again, another set of estimates, but these can be helpful when interpreting trial results when surrogate endpoints are used and determining if said results are clinically significant. So back to the previous example, an A1C reduction of 0.6% is generally considered to be clinically significant. However, it's important to understand that even though there are several established threshold values for clinically significant changes with surrogate endpoints, at the end of the day, they are all predictions used to estimate the intended treatment benefit of lowered morbidity and mortality outcomes. So, what's the takeaway message? The key understanding is that statistical significance does not automatically translate to clinical significance. Clinical significance is a little bit more subjective compared to statistical significance, and determining clinical significance can be challenging. But hopefully what we've covered today will increase your ability to do so. Thank you again for listening. I used several resources for this review, and I'll list them below when possible. Please refer to them for more thorough and comprehensive information on the subject. And if you like this review and want to get a little bit more information on landmark clinical trials, please visit my website at www.highpoweredmedicine.com. And if you create an account, you can download 10 free trial reviews from the second edition of my book, High Powered Medicine. Thank you again for listening, and have a great rest of your day.